years ago. Mental illness was not included in people's health plans. And so if you couldn't afford to pay out of pocket, you were not afforded the health care that you deserve in order to stay stable and secure and maintain a state of wellness. At that time, many people were institutionalized or had marginal care or no care at all. So we've come a long ways, but we have a long way still to go because there's still not parity in the services being offered to individuals with mental illness. This is one of the things that I say a lot, that for years we have thought of the body from the neck down. We talked about all body systems from the neck down with comfort and ease and study. And from the neck up, we're still whispering or not talking at all about the conditions that are in the brain that makes up our mental health and our ability to think, act, and be responsive in a way that is conducive to good health. So that is still a major difficulty, not only for the individual who's living with the illness, but it's also difficult for society as a whole. Again, why I applaud you and what you're doing and bringing lay individuals in to begin to understand and to be open and to be accepted. We still have a difficult time reconciling about this illness that occurs above the neck. But to the individuals who are taking this class, as you progress through your classes, I am sure you will gain a different perspective in what it means to address an illness that occurs above the neck, namely mental illness. What that will mean to you, what that means to the individual living with a mental health condition or mental illness, and what it means to society at whole, as a whole, as we view how we treat, respect, and engage people with mental illness. And so I'm just going to stop there and say I congratulate you. I applaud all of you for initiating this program. You now will become partners with the rest of us. I would like to also say that NAMI DC or NAMI National, NAMI all over the community, all over the states, we deal with the family members of people with mental illness and the individual who has openly disclosed that they have a mental illness. As we still have individuals who are not even comfortable disclosing that factor. But you will be beginning to deal with the community and helping other people recognize and understand that this is an illness that only as a community we can eliminate the stigma, we can eliminate the shame, and begin to engage in healthy, wholesome conversations and looking to recovery and resilience, the words we use. And perhaps all of you at NIH will even be thinking about the cure, because right now we're still talking about resistance and recovery. The cure is still a process that we are still moving towards, with the hope and the encouragement of more brain studies or more brain having brains available post-death in order to do research. So it's still a researchable area that needs much work. Congratulations and thank you for all of those attending. I see you have a great number, a great start. Thank you for inviting NAMI DC.
Thank you so much, Ms. Harris. We really look forward to working with you and getting to know you a bit more. Hopefully everyone else will have the opportunity to, reach out if you all need anything.
We will be in touch, yes.
Thank you. Okay, so I just want to introduce a bit more of people who are working behind the scenes. So these are our educators. So the majority are residents from Duke University Hospital, with the exception of Dr. Bronner, who's an attending physician at Duke University Hospital, and Reverend Pam, who is one of our religious partners. So you'll get to meet them a bit more since they're going to be the ones leading the future workshops. Okay, so on this slide, we have the Lay Mental Health Advocates email. So if you all ever need anything, that's our primary email. We also have a website, which we will send the link out for. The website will be useful more in the future when we upload these PowerPoint presentations and more resources for you all to utilize. And we also have a GroupMe, so we will send the GroupMe link in the chat here so you all can join easily. But if not, this link was sent to you via email when you all received the syllabus. So please join that. And just to end this part of the presentation, this is an outline for what's going to happen today. So next, we're going to have a presentation on social determinants of health. And we're going to have a short debrief on the game that we all played before coming to this workshop. And after that, we're going to talk about structural racism and neighborhoods, the impact on mental health, access, and outcomes. And just to finish everything off, we'll have a summary and reminders for next week. And don't worry, it's going to be a lot of good information. So we'll have a short break somewhere in between this. So now I'll just go ahead and pass it on to Bruni, who's going to be leading the next portion.
Hello, everyone. So this is the beginning of the lecture on social determinants of health from identification to advocacy. And this lecture was adapted from a lecture given by Tiffany Israel, Jewel West, and Gordon McDonald from Vanderbilt University. The overall objectives of this seminar will be to define inequity, inequality, and social determinants of health, as well as describe why social determinants of health are relevant to health outcomes, and critically consider your role as an advocate. So the first thing we're gonna do is debrief about the Spank game. Now, one of the things I would like to remind you guys is that the more you engage, the more you learn. So please engage as much as you can. We're gonna have you guys break up into breakout rooms and discuss a couple of questions. So first, just introduce yourself. Talk about what you found the most surprising about the simulation, and talk about whether these experiences were different or similar to your own. And how would you say these different life experiences that happen while you play the game might affect your access to mental health and your mental health in general? So we're gonna break you guys up into the breakout rooms in just a few minutes.
Okay, we're just going to take a quick note of, you'll want to memorize what these questions were. We'll try to put some notes for what the questions were in the chat in case you all forget. But I'm going to go ahead and break you up into breakout rooms and just click accept. This will be just a few minutes, so get as much as you can out of it, and you'll get a warning when it's time to come back to the main room. I'll just let Daniela finish typing the questions.
And we're looking to be there for around 7 minutes, so you'll get a 1 minute warning.
Stand up for themselves and assert their rights and not be exploited for their labor. So that was definitely one thing that surprised me and was super frustrating when I had played it.
I agree. Oh, wait, I forgot to introduce myself. I'm Advika. I'm a first year undergrad at Duke right now. Something I also found interesting in the simulation was that there really was no way to win. I made it through the month, I kept my job, but I had to sacrifice time with my kid during the game. I couldn't actually support my colleagues. I couldn't really take time to buy enough groceries to actually be comfortable or have nutritious food necessarily. And there were just a number of options.
This country go through, so it was just very telling.
Hello, everybody. My name is BJ Brown. I'm a first-year postbac at the National Institute of Mental Health. For me, it was really surprising just how emotionally distressed I felt playing the game. So it's like I can only imagine what someone who is actually living this as their reality is personally going through. And something that was surprising for me a little bit was how even when you want to do the right thing, you necessarily can't always do the right thing. For instance, she wanted to pay, well, like I was thinking of a woman in my mind, you know, providing for her kids, wanted to pay her car registration or for her car tag. Otherwise, it would
that tend to criminalize being homeless. And so I feel like this game made me realize, or made me think of these things, that what happens after the fact that you have $0? What are the whole cascade of problems that people have to experience once they're homeless, once they have nothing to their name, once they pretty much don't know what to do? This goes to show that there's a whole bunch of mental illnesses that can be, you know, created as a result of this. So I think this game was really nice to see the fact that we were able to put ourselves in somebody else's shoes, but there's a whole cascade of things that happens after the fact that we after we hit $0. So that's my takeaway from the game.
Hey, did everyone get a chance to talk and or introduce themselves? Okay.
Not yet. Here, I can go real quick. My name's Spencer, and I graduated from Indiana University this past May. I agree with what everyone else has kind of shared, and I think one of the most striking things that that one of my takeaways from the game was that it takes money to have security. And for example, like health insurance, like that was a really tough decision to know and have looming. Let's say you decide not to do it, have looming over your head, all of these major expenses and everything else like that. Just the uncertainty in your future can really eat at someone's mental health. And your mental health ends up rolling over to so many different things. So it was a really striking game. And I thought you made a really good point, Corbin, about how when you run out, we just restart the game and try it again. But in real life, you have to face some really serious consequences. So.
What's up, everyone? I'm Sir, and have more expensive rent or farther away and have less expensive rent. I really resonated with that question in the game. But yeah, and we'll popcorn over to Anand.
Hi, my name is Anand. I'm a freshman at Duke University. And I think one thing that really stood out to me from the simulation was I just felt like this tension in all of, like in each question throughout each day, because it was like, am I going to run out or not? And I felt like that just in a simulation. So, you know,
far into the game, $10 looks like a lot. But yeah, and then some of it, in terms of experiences, I haven't experienced fortunately a lot of this, but definitely with certain circumstances would have to have my parents to like definitely choose between certain items between, I guess, like going to work or seeing plays. That part definitely resonated with me.
Oh, I'll just let Bruni come back because she's going to go on with the presentation.
Alrighty, hello everyone, and welcome back. Sorry if that seemed rather abrupt, or if you guys were given some times. But was there anything that was said during the breakout rooms that anyone would like to just briefly summarize? Anyone? Just one person.
I can go. One thing we talked about, a few people brought up, was that even when we thought we were spending our money well, the game did a really good job of bringing up surprise expenses, like you need a dental procedure or you have a car problem, and you could either like postpone those payments or you could go ahead and do them, but they take a pretty big chunk out of what you have. Um, so that was something that a lot of people in our group found surprising or like more realistic.
Thank you. Thank you for sharing. Yeah, so a lot of common things I found while I was hopping through the groups was that, there was no way to win. It seemed almost as if like everything was working against you. And even when you made the right choice, you were losing something and it was something big, right? And so we'll touch a little bit more on that later. But first, I want to just define what health is. And health is not just the absence of being ill, but health is a state of complete physical, mental, and social well-being. And so it's not merely just not having a disease, not being sick, but it's actually being well, both, emotionally and making sure like everything that's working is supposed to be working. So, how can we change the way we treat patients to ensure long-lasting results and prevent future health issues? So let's look at the right to health, right? The right to health encompasses both underlying determinants, which include access to water, sanitation, food, nutrition, etc., as well as healthcare. But in order for those two things to work together, there has to be something we call AAQ, which is availability of these resources, accessibility, acceptability. So the people who are using it have to be okay with using it and understand the benefits to using it or the harms to not using it, and quality, right? Giving water is not enough. The quality of the water has to be good in order for the health to be good. So we're going to talk a little bit about some of the social factors that can affect someone's health. So there is the social gradient, in which the poorest of the poor around the world have the worst health, right? It seems like almost rocket science. The poorer you are, the worse off your health will be. There's also social determinants of health, which are circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with these illnesses. So social determinants are complex and integrated and overlap social structures and economic systems. So these social determinants of health include, but are not limited to, your socioeconomic status, discrimination, whether or not you experience it, your quality of housing, your physical environments, food security, working conditions, right? So there's all these different things that are important in social determinants. There are also your physical determinants of health, which include your natural and built environment. So we understand a lot more now how much the environment you live in can impact how you live your life, right? There's, stories about how in poorer neighborhoods, there are oil rigs that have been built. And I recently heard a story where there was this woman who was getting crazy nosebleeds and was experiencing all the health problems. And they told their doctor, oh, by the way, we live next to an oil rig. And the doctor takes off his glasses and he's like, oh my goodness, you guys have to move. But when you look at those oil rigs in richer counties like in Beverly Hills, right, there were things put in place to prevent the oil fumes from getting out there, right? There was walls built to make the gas go up instead of into the communities. There are things put in so there wasn't noise. So we really see how your physical environment can affect your health. And last but not least, health inequities, which are disparities in health for healthcare that are systematic and avoidable, and therefore considered unfair or unjust. So I'd first like to ask you guys a question about what is equitable care. So this is one of the polling questions. We're gonna pull it really quickly And this is anonymous, so just answer as honestly as you can. What is equitable care? Is it the same care to all patients regardless of their race or ethnicity? Is it care that guarantees equal outcomes for every patient? Or is it care that provides the highest quality care for all patients regardless of their race or ethnicity, even if that means different care for different populations? And then the last option is care that is delivered by providers who have been trained in cultural competence. So we'll give it a couple seconds. We're gonna allow you guys to fill it out. All right, we're at 70, 80. All right, so polling has sort of gotten stagnated. So it looks like the majority of you guys say that equitable care is care that provides the highest quality of care for all patients, regardless of their race or ethnicity, even if that means different care for different populations. And that is the correct answer. So often people confuse health equity with health equality. And we're going to talk a little bit about what the main differences are. So first, the social determinants of health are conditions in which people are born in, grow, live and age, work. It includes their health system, is shaped by the distribution of money, power, and resources, both on the global and national level as well as local, and is mostly responsible for health inequities, which is the unfair and avoidable differences in health status seen within and between countries. So before we get to the definitions, I'd like to just show you this graph on social determinants of health, in which the outer layers are general social, economic, cultural, and environmental conditions that affect your health. And as we get closer and closer to the core, these are the main factors that encompass social determinants that can affect how good or how bad your health is, right? So we start out with just your living conditions, your working environment, education, but it goes into your social community and networks, as well as your individual lifestyle choices, right? What you eat, do you smoke, do you drink? And then to the core is your age, sex, and constructual factors. And when I say constructual factors, I mean things like race, that is a construct, but because we've made this construct such a real thing, it greatly impacts everyone's realities in this world. So there are a couple definitions for inequality, right? There's difference in status, there's lack of equal treatment, and there's state of being unequal. Of course, there's also the mathematical definitions, but we don't need to get into that. Now, when it comes to inequity, right? Inequity is unfair treatment, right? Lack of fairness or justice. And it's also unfair situation or action, right? So often when people compare equity to equality, we think about what is needed to get, what do people need, right? What is needed to get people to equal levels? While inequality is just lack of there being equal opportunity, inequities are things that can be fixed to be equal, but are not just based on the current circumstances that are there. And so when we talk about health and equity, if it's unequal but avoidable, then it's inequity. And that is one of the main differences. If it's unequal but avoidable, then it's inequity. So what are health inequities or inequalities? Health inequities are avoidable inequalities in health between groups of people, within countries, and between countries. These inequalities arise from inequalities within and between societies, social and economic conditions, and their efforts and their effects on people's lives determine their risk of illness and the actions taken to prevent them becoming ill or treat illness when it occurs. So when we talk about health equities, let's first look at the United States. This is a map by the Robert Wood Johnson Foundation. And on it, you see that different parts of the US have different life expectancies, right? Someone living in Montgomery County, Maryland has a life expectancy of 81.3 years, while you go down to South Carolina and that drops to 69.6. So even in our own countries, right, land of the free, land of the equal, your life expectancy can be drastically different just based on which state you live in. And it's not just which state you live in, and it goes deeper, right? Even within your own states, there are differences in how long you can live. Living in somewhere like Florida, right? Some people will live life expectancy up to 81 years, while in some places the life expectancy is 70. That's a more than 10-year difference life expectancy within just one state. There's even some bigger differences like South Dakota, where the life expectancy differences, depending on where you live, can differ by 13.7 years. And so just take a second and find your state and see, you know, how much of a difference is there in life expectancy just based on just within the places that I live. And, you know, even within the state, we can go to a smaller jurisdiction, my current home of Washington, D.C., where in the downtown area, which is a more urban area, you have life expectancy of 72 years. But you take the metro and this red line the metro and travel just 30 miles, and the life expectancy difference is 9 years, right? You take the green line, you travel up the green line, and your life expectancy increases by 3 years. So we see that even in small places, right, there are huge disparities in health, and there are large disparities in life expectancies. And so that sort of has us think a little bit more about what is causing these differences. Why is it that one person that lives only 10 miles from another person can have 8 years more of life than another? You could do a lot in 8 years. You could do a lot. So losing that time, right? What makes it so unfair, and what makes it is this equitable? And so what can be done about this? So I first want to say this quote: "The poorest of the poor around the world have the worst health. Within countries, the evidence shows that in general, the lower an individual's socioeconomic position, the worse their health. There is a social gradient in health that runs from the top to the bottom of socioeconomic spectrum. This is a global phenomenon seen in low, middle, and high income countries. The social gradient in health means that health inequities affect everyone." Everyone. So this health impact pyramid sort of helps us understand what we can do about social inequities. This pyramid illustrates the impact of different types of health interventions. So let's start at the very top of the pyramid and work down. So counseling and education, specifically in clinical and other settings, is regarded by some as the essence of public health action. But unfortunately, it's not as effective as we would like. That being said, at times, counseling and education are the only forms of intervention available, and when applied consistently and repeatedly, can actually have an impact. Examples include putting labels on cigarettes. I know in some countries like Australia, they have literal pictures of someone's like deformed throat on the cigarette packet, so that you see that every time you're flipping it open, right? The US is a bit less extreme, but I know some parts of the US does do that. Moving to clinical interventions, ongoing medical care for a health condition is an example. In the case of cardiovascular disease, these interventions could have a considerable effect. However, we're limited by lack of access to certain patients who need care and lack of adherence to medical instructions in the real world. So as we know, the US has one of the worst medical systems of all the first world countries. And so that means a lot of people are missed when it comes to care. And, you know, the history of injustices done by the medical system and done by the US government, and honestly legally sanctioned things against people of color, has led to there being lack of trust in the medical system and therefore lowered adherence to the instructions in the real world. Long-lasting preventative medicine interventions, such as vaccines, prevent 2.5 million deaths amongst children around the world every year. In this case, a single dose or instance of an intervention can have a lifelong effect. But again, going back to our previous one, if people don't believe the vaccine works, they won't take the vaccine. And so that part of the pyramid seems to almost drop out. We make health decisions to default by changing the context in which behaviors occur and making it difficult to avoid the intervention. For example, changing the laws to require seatbelt use in cars, banning smoking in public areas have a significant impact. Now, finally, at the base of the pyramid are public health interventions that affect socioeconomic factors. If we can improve quality of life by helping people out of poverty, providing basic sanitation, and improving their access to education, healthy food, and medical care, we can greatly improve people's chances for a healthy life. So back to the major barriers to for having care, right? Care is at the top of this pyramid, but some of the major barriers include lack of consistency in care, cultural and linguistical challenges. There are not doctors that can speak all languages. I know particularly sometimes deaf people don't have ASL translators. Access to affordable care, again, the United States does not have good medical care for all. Hopefully that changes soon. The access period to getting that care, navigating the system, past experiences with the healthcare system, particularly people of color who have had negative experiences or have experienced racial bias, and trust. And trust is one of the main things sometimes that prevents people from even going out to seeking care, because they don't even believe that the doctors can do anything for them, or even worse, they believe that going to the doctor will cause greater harm than if they just stayed. And so this graph sort of shows the barriers to health amongst non-elderly adults. And so we see the dark blue as people who are uninsured. And people who are uninsured at 55% have no usual source of care. At 42% have no preventative care. And those percentages drop drastically once there's some form of care, whether it's public care or private insurance through your employer. So we really see the difference that having medical care can have on not only getting preventative care so that things don't happen to you, but also just being able to afford medication when things do. So what else can be done, right? One of the things that physicians can do, and you as advocates will be tasked to do with your given health seekers or patients, is really engage your patient, right? And this includes having personal connections. Those matter. There was one large study that surveyed over 2,500 participants and found that nearly 1/3 had marginal or inadequate health literacy. Of these people, 42% misunderstood directions for taking medications on an empty stomach. 25% misunderstood the scheduling of their next appointment, and nearly 60% were unable to read and understand typical informed consent documents. So we really see how much there's just a gap in understanding between patients and physicians. And we often see in studies that empathetic communications involving a thorough understanding of the patient's perspective improves adherence by a lot. Patients who are informed and effectively motivated are also more likely to adhere to their treatment recommendations. These findings also illustrate the importance of psychosocial elements in medical encounter and their contributions to improving patient adherence, right? So we talk about cultural sensitivity, getting to know the community and population that you're working in, using the advanced technologies available to you to increase communication and engagement. Variable importance of the same ethnicity and background. So although there is some research that show positive correlations and outcomes of partnerships when patients and physicians are of the same ethnic backgrounds, other studies have failed to demonstrate this effect and suggest that matching physicians and patients according to their ethnicity is not necessary. So one thing I will say about those studies is that the studies that found that, you know, when there was race concordance, right? When there was a Black physician with a Black patient, health outcomes were greater. When they actually looked at the data, they found that the only difference within the physicians that had greater outcomes and the physicians that didn't was that the physicians that had greater outcomes with their patients just talked more with their patients, right? They would write down things like a child's birthday on their notes, and not just, you know, technical jargony medical stuff, but, you know, what do they have birthday coming up? They talk about, you know, maybe there was a game on that was interesting, life events that was going on. So really the barrier to patient engagement is literally engaging patients. And taking the time to get to know who the patient is, get to know what their beliefs are so that you can give them personalized care and increase adherence. So patients must be given the opportunities to tell the story of their unique illness experiences. In some disease conditions, more than 40% of participants sustain significant risk by misunderstanding, forgetting, or ignoring healthcare advice. So what works? Realistically assessing the patient's knowledge and understanding of the regimen, right? As advocates, you'll be tasked with, meeting up with a patient or a health seeker and understanding what is going on with them, right? So realistically assessing what they know and what they don't know will give you a baseline to then where you can fill in those gaps. And filling in those gaps in a way that they understand and the way that resonates with them is going to be very important. Another thing you can do is have a clear and effective communication between the health professional and their patients. So that being said, if a person has already a mental health professional, studies show that keeping in communication with your physicians, having a follow-up is the best way to increase treatment adherence. And finally, nurturing trust in therapeutic relationships. Again, especially in marginalized communities, there is great mistrust in medical institutions. And so part of your jobs as advocates will be to help nurture that trust by not only, admitting and, validating the fears about medical injustices, but also helping people understand how far we've come, how far we still have to go, but things that have been put in place that make things safer, particularly vaccine trials and other trials in this country, and regulations such as the IRB that has been put in place to make sure that people are safe, as well as communicating the importance of going to the doctor frequently or participating in clinical trials because representation matters. Physician-patient partnerships are essential when choosing amongst a variety of therapeutic options to maximize adherence. So if a person is not doing so well with their physician, that usually switching a physician if they can greatly help them. So again, we have discussed some of the ways to improve effectiveness at the top of the pyramid. However, it's really the interventions at the base of the pyramid which have the greatest impact on the health of populations. So where do we start in our own communities? So the typical community resources that exist include emergency food, housing, resources for domestic violence, utility and rent assistance, mental health assistance, healthcare, child and family assistance, disaster relief, unemployment, legal services, assistance to help you get your GED and increase your literacy, as well as substance abuse assistance. So this graph sort of shows why referrals matters. The Feeding America Network Food Bank provides service to 46.5 million people in need in the United States. This client survey is a representative of one region affiliate of the many others in the country, and it demonstrates the practical decisions that individuals in poverty must make that impact their health greatly. So this graph shows how frequently an average household at the Middle Tennessee Hunger in America, near the Middle Tennessee Hunger in America organization has to choose between food and other necessities. So you see that, medication is one of the biggest ones because, again, our healthcare system is not the best. People have to choose between food and their medications frequently. And that is literally choosing between life and death for some people. There's also housing and rent, which people have to choose between, and transportation, right? Because of the incentive to, pump more money into highways and make more cars, transportations in cities have not been the best. And in fact, they've been defunded. And so in a lot of cities, transportation isn't best. And we see that mostly Black and brown people are the ones being affected the most by these defunding transportation, and as well as utilities. So that's why it's so important to be able to understand the resources that you can help people with when they come with problems that have to do with choosing between medication and food, and helping them find housing and other resources. So once the need is identified, it's important to connect the patient with resources to address it. So confirm that the patient understands and agrees with the instructions and the next step. So it's not just one thing to just, oh, here's a resource, figure it out, but also make sure that the health seeker understands the resource that they're getting, how it works, right? What the number is, and follow up after you've given those resources, see how it panned out. If it didn't pan out so well, then I guess we have to sort of go back to the drawing boards and try again. So again, identify the barriers to success. Those can be literacy level, it could be stress, it could be financial means. But after you identify barriers and try to tackle them, always make sure to follow up. So what? Social, economic, educational, and political factors impact health. So I want you guys to sort of think about that to yourselves and really spend some time to think about, what does this mean to you as a citizen of the world, and what does it mean to you as an advocate? So now we're going to take a short 5-minute break. You can take some time to stand up. It is currently 8:01, so we'll commence at 8:06. This is also a time where people can ask questions if they'd like, or just general comments about how they feel. So we'll be back at 8:06. Your house and stealing something, right? What is the picture of that person that you get? And if the person that comes to your mind is a Black person or brown person, just understand that the way that things have been constructed, it has been constructed to make it seem as if Black and brown people are natural criminals, right? Just by the basis of their skin. And that is in no way true. And, just so you know, there are people who are making these laws that also understand that they're trying to criminalize Blackness and are trying to do a roundabout way. In fact, someone from Nixon's administration actually admitted to creating this war on drugs to target Black and brown people as well as anti-war veterans. So I'll actually read this quote by this Nixon aide. You want to know what this is really all about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war and Black people. We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on evening news. Did we know we were lying about the drugs? Of course we did. So just briefly, can someone just tell me what their reactions are to this quote? You can unmute yourself.
Not surprised. As a Black female, I kind of grew up knowing Nixon, kind of thinking Nixon and Reagan were like the worst presidents. At least that's what my parents told me. And it was because of this reason. And they would say, oh, they would always put us on the news. And that's not always true. It's just because that person looks like you doesn't mean that you yourself are a criminal. So just kind of backtracking that. And then to answer, just a little bit of the question you said, who comes to mind as like someone, like if somebody's coming into your house, who comes to mind? Like for me, it would be different. It would be maybe a police officer. So it's very different. I wouldn't think, oh, a Black man or whatever, which I've had a few classmates say, oh, your dad looks like a criminal, but my dad's a doctor. So it was really weird. It was like, but he's a Black man, you know what I mean? So yeah, it's just, this doesn't surprise me at all, which is kind of sad.
Yeah. Is there anyone else who'd like to just give their reactions?
I actually watched the documentary, I think it was last weekend. I really enjoyed it. So I did hear this quote then. And, hearing it then and hearing it again now, like I think it was Ty said, it's not surprising. I mean, I feel like a lot of people in the Black community, like we don't have to like hear it, like physically hear confirmation that this is what people are thinking, but we know that this is what's going on behind closed doors. But what was really frustrating hearing it during the documentary and again reading it now, is that this is, you know, this is out in the open, this is public knowledge, but you know, the war on drugs is still happening. You know, retribution for what has happened to my community is, it hasn't, you know, nothing has been made up for this, and we have the evidence right here in plain words. Yeah, we literally just did this to target Black people, brown people, and people against the war that we're promoting. So it's just really frustrating.
Yeah, very true. Thank you for sharing. One more person. Anyone like to just? No. Okay.
There's a quick question for you, Bernice. Do people still go to prison for very small amount of any substance?
Yes, yes. People go to prison for life in some places for just a gram of weed, and they're locked up for life. And so when you think about that, and you think about, you know, who is the face of, you know, this criminal drug exchange, right? When you think about who is bringing these things to the communities, right? Black and brown people, they tend to not be the ones with the boats and planes bringing these things into the communities. We know who's bringing it into the communities, and it's not the same people going to jail for it, right? You have people going to jail for their whole lives, but people who are doing things such as environmental crimes that will affect us for literally generations, are walking free, right? Are getting just fines, right? So yeah, so people still go to jail for weed. In fact, we are seeing that, you know, Oregon has decriminalized all drugs, and you know, someone else who hears that would say, oh, like what are they doing? Even like people are going to be taking heroin on the street, but what they're actually doing is decriminalizing drugs, making there be like a monetary penalty, and then using that money to fund rehabilitation centers for people, so that, you know, they're actually treating drug dependence as a medical issue rather than a criminal issue. And again, going back to the opioid crisis, right? I talked about how in the 1800s, opioids were made legalized in order to target Chinese immigrants. But now the face of the opioid crisis has changed, right? It is now white people. And the rhetoric and the conversation around the opioid crisis has drastically changed, right? There are not mothers being thrown into jail for having a biological dependence on a drug, right? There are trying to be incentives to like put them in hospitals. So we really see that race matters when it comes to what the war on drugs really is about. And it's not really a war on drugs, but actually a war on minorities. Yeah. Were there any other questions? All right. So I'll just continue then. Thank you everyone who spoke. So we see that poverty and segregation really affected John W.'s life, right? John came of age during the busing crisis and the war on drugs, right? People were going to jail all around him. He wasn't getting adequate education because, you know, the Boston system was illegally preventing him from going to adequate schools. He experienced more than 50 prior arrests, mostly drug-related charges, right? Someone who's experiencing mental health issues, taking drugs, is also being thrown into the criminal justice system that, you know, started out as, oh, well, like the criminal justice system used to be a rehabilitation, but now it has become a place of punishment. But how much do you punish someone who has biological dependence to a drug and needs help, right? And so his longest sentence was 9 months, but he served a total of 4 years. So 4 years of his life he spent in prison. And following his last incarceration, he separated from his wife and he lost housing, right? His support systems fell away. He ended up moving to a veterans shelter, and his son, John Jr., is now being bused from Roxbury to a junior high school in a wealthy Boston suburb. So that you see that his son is luckily getting some of the things that he wasn't able to. But is that enough to stop the impact that his life, that events in his life has had? So next we'll be talking about structural racism in neighborhoods, the Gray and Boston, Washington, D.C. area. And that lecture will be by Daniela.
Yes. Thank you, Bernie. I appreciate it. All right, y'all. So we will now broaden our scope from an individual case to looking at regional disparities in two US cities, which are used as an example in this case, Boston and Washington, D.C. And these cities are both good examples of structural racism against African Americans as evidenced by neighborhoods. And so if you look at this slide, on the left, you have a map of Boston and the greater Boston area. And on the right, you have a map of Washington, D.C. And so the map of Boston is divided by zip codes, and the zip codes in the inner city, which are the poorest neighborhoods, are disproportionately populated with Black Bostonians as compared to neighborhoods on the fringes of the city, which are more predominantly white neighborhoods. And if you look at the map of Washington, D.C., you will see, and by the way, these data of the map from Washington, D.C. is from 1990 through 2016. And this map was made by the Washington Post, and it shows that Washington, D.C. is deeply divided from both west to east and north to south. And the northwest Washington, D.C. is predominantly white, and the southeast Washington, D.C. is predominantly Black. And so now let's take a closer look at DC and DC's wealthiest neighborhoods. And so this is census data from 2006 to 2010, and it maps out the median income of neighborhoods around the city. And so if you can look at the map, you will see that the neighborhoods which are green are in the predominantly white area, and the neighborhoods which are red are in the predominantly Black area of DC. And so this illustrates comparative wealth. The greener the area, the higher its median income. And the redder the area, the more impoverished the area is. And the darkest green here indicates a median income of at least $134,000 a year, while the red areas indicate that the area is struggling with poverty and the median income is $22,000 a year or less. And so we can see here, there's a clear disparity in the wealth distribution across DC. Next slide. And so now let's look at a map of Boston. This is a map of the foreclosures by neighborhood in Boston. And it's foreclosures from 2008 and 2009. And so again, looking at this map, we can see that the neighborhoods that are majority Black have the highest rates of foreclosure. And foreclosures are important as a marker of poverty and in some cases, lending inequity. And as a quick definition, foreclosure is when the lender takes back property when the homeowner fails to make payments on a mortgage. And so here, this map again shows significant wealth inequality in Boston. Next slide. So now we'll take another look at a map of Boston, and this one is unemployment by neighborhood. And then this is again 2009. And so just reiterating our previous point that was made, there is clear and disproportionate rates of unemployment by neighborhood, and they correlate almost identically with geographic segregation. And so again, this is just showing another way in which race is structurally linked to poverty. Next slide. And so we need to illustrate how specific housing policies directly correlate with these disparities. And so beginning in the 1920s, there were racially restrictive covenants which prohibited Blacks, Jews, and other racial minorities from buying property in wealthy neighborhoods. But beginning in 1934, there was the federal laws were enacted that further increased residential segregation. Redlining was one of those policies that was enacted in 1934. So the FHA, or the Federal Housing Administration, was created in 1934, as well as policies that, such as redlining, that were adopted as a way to restrict favorable lending from reaching inner city communities. And so redlining is specifically the systematic denial of various services or goods by the federal government and its agencies. And so essentially, it made it really difficult for African Americans and other minorities to get mortgages for homes. And so the implementation of these policies accelerated the decay and isolation of minority inner city neighborhoods. And it made it difficult for these neighborhoods to attract and retain families who are able to purchase homes. And these discriminatory policies exacerbated residential racial segregation. Further in Boston, especially, the impact of major highways from the 1950s through 1975 significantly impacted inner city neighborhoods. These highways were built and they reinforced suburban resources, and they left inner cities destitute. And we continue to see until today a disparate impact of local land use regulations around the United States. And this is not just in Boston and Washington, D.C. We see this in other areas as well, like Chicago and Detroit. So yes, I think that's it for my slides.
So now we'll broaden the scope from a neighborhood level and looking more so at national trends and structural racism in neighborhoods. And so when we're looking at structural racism in inner cities, nationally, about 80% of residents in high poverty urban areas in the US are minorities. And African Americans in particular account for half of residents in high poverty urban areas. And when we look at even larger epicenters like Chicago and Detroit, this number is even higher, between somewhere in the 80s and 90s. And so nationally, 27% of 34 million African Americans live in poverty today. And by comparison, the poverty rate for whites is roughly 9%. And so taking all of that into account and kind of circling back to the conversation about health, a lot of times when we think about health, we think about the direct impacts of health, right? So like exercise, diet, genetics, and so medical care and personal behavior has clear direct links. But it's also important when we're looking at health, think about the social determinants as Bernie was talking about earlier. So living and working conditions in your homes and communities, right? So it's like, what is your neighborhood like? And how does that affect medical care and personal behavior? Because how can we talk about needing to exercise when you don't have a gym, a track, a basketball court, a safe playground in your neighborhood? And even on a broader scale, if we look at the economic and social opportunities and resources, that also influences the living and working conditions, right? So you can't move into a neighborhood that has these things if you don't have the economic mobility to do that. So really, health begins on a national scale, begins at a large economic and social scale. And so we can't look at a lot of these health issues as individual actions when in reality, there's so much happening on a systematic level that's impacting whether people can make these individual choices for their health. And so looking at racism as a social determinant of health, you can see that racism really impacts literally every aspect of life, right? So if we look at racism in education, we can look at, like, you know, plenty of colleges. What are the rates of Black Americans? What are the rates of Latinx Americans? And then looking at job opportunities, socioeconomic status, environmental exposures, health behaviors, access to health services, what kind of housing, and violence. And so since racism, especially in the States, is so deeply rooted in all of these things you see in the middle column, and these also have direct impacts into health outcomes, racism is, at the end of the day, one of the biggest public health crises we have, just because of how intertwined it is to nearly every social determinant of health. And so could you go up a slide, Brittany? Yeah, so looking at the concept of neighborhood disorder, instead of formulating illness as existing solely in our patients, what if we begin by where they live and asking not just, is this person sick, but is their neighborhood sick? And so if someone's living under the constant stress of poverty, segregation, and violence, how can they be expected to have good mental health, right? So if you're looking at all these factors that happen in a neighborhood, you can see clear correlations between communities in a neighborhood and what kind of mental health outcomes they have, because they are experiencing the same traumatic events if it is in a high poverty area versus, you know, more affluent neighborhoods would have a significantly reduced occurrence of a lot of these mental health issues strictly by where they live. Next slide. And so, yeah, looking at how neighborhood disorder impacts mental health outcomes, we can take, for example, like I grew up in my early life in LA and specifically in Inglewood. And so there, like, gangs are a huge thing. Like, you aren't really going out by yourself past sunset. And so a lot of these things you can see impact people, especially younger people, younger women, and like the type of anxiety you feel going out in certain times of the day. And you contrast this, like later in my life, I went to high school in a city called Torrance, which was in a much more affluent area. And there, you could be going out just like, a group of teenage girls on your own at nighttime and feel completely different than I did back home. And so those feelings of anxiety that I felt in one zip code versus another isn't a coincidence. And you can kind of see in this flow chart how neighborhood characteristics, so something like, are you seeing public drunkenness? Are there corner gangs? Is there street harassment, drug trade? And as well as the physical structures, right? So are there abandoned buildings, vandalism, litter, what type of housing is there? And so that directly connects to the fear of crime and then the likelihood of being incarcerated for crime or being incarcerated not for crime, right? Because a lot of times incarceration isn't rooted in any truth. And so these things all have a direct impact on many mental health outcomes, including anxiety, depression, different somatic symptoms, PTSD. And so the neighborhood itself has such a huge impact on one's mental health.
So now we're going to look at how everything we've just learned affects access to mental health care. So one of the biggest factors in one's mental health journey or experience is both physical and financial access. So redlining's lasting effects include limited to no quote unquote luxury health services, which run from supermarkets to dental clinics to mental health services. Because of redlining, Black people are 7.3 times more likely to live in these high poverty neighborhoods. For those who do live within accessible distance to mental health care, the cost is often prohibitive, necessitating insurance coverage. However, 25% of Black people are uninsured, compared to 16% of white people, which is a 1.5-fold increase. Many people rely on their jobs to insure them. However, disparities exist here as well, with only 53% of Black people receiving insurance for their work from their work, compared to 73% of white people. This results in uninsured Black people having a very high utilization of safety net services, such as emergency rooms and inpatient settings. However, mental health care access is not only related to living in high poverty, underinsured socioeconomic states. The percentage of Black people receiving treatment from any source was only about half that of white people. There are several reasons for this, including location. 15% of Black people live in rural areas where mental health care professionals are less likely to be found. In addition, due to a long and complex history of uninformed consent, biological theft, and the lack of scientific benefit to their own communities, many Black people distrust the medical establishment, and rightly so. This is especially true of psychiatrists who frequently misdiagnose Black people with schizophrenia and major depressive order, as a 2019 Rutgers study found. Going to a Black physician might help alleviate this mistrust if you are exhibiting symptoms of mental illness, but there are very few Black providers. Only 2% of psychiatrists, 2% of psychologists, and 4% of social workers are African American. So due to all these reasons, Black people are about half as likely to receive counseling, which is what this little graphic shows. Next slide. And even less likely, about only 40% compared to 100%, like 4 to 10 ratio, to receive psychiatric medication. So, and we've been focusing on Black populations, but all across the US, all non-white mentally ill Americans utilize much fewer resources, mental health resources, than mentally ill white Americans. Also note, so that's the infographic on the left here. And on the right, we can notice that in Massachusetts, Black people are almost just as likely to receive medical care as white people. So if we think about our case study, Mr. John W., who's from Massachusetts, this means that John W., with all of his, all of the things that he's experiencing and all the hardship he has to go through, he is kind of one of the lucky ones. He has access to mental health care, and there are still all of these complications. So just because you have access even doesn't necessarily mean your mental health will be good.
All right, so thank you, Jesse. So, okay, we're nearing the end of the presentation, so just bear with us. I'm going to go through a few quick facts that some of you all may be aware of, but those who aren't, it'll be useful to know. So, next, okay. So the psychophysiological stress response is associated with living in a neighborhood with high crime rates and drug use. Residents of disadvantaged neighborhoods drink more heavily than residents of more affluent neighborhoods. And lastly, low-income youth in Boston are more likely to have poor cognitive development and substance use. Remember, these are focused on Boston, but the same things can apply to many other cities. Okay, so intrusive encounters with police are associated with more trauma and anxiety symptoms. This was, all over national news in 2020. And it got a spotlight last year, but it's been happening for so long. So it's also important to keep, just be aware of what's happening in the many places around you. So now over 25% of African American youth have been exposed to violence severe enough to warrant a diagnosis of PTSD. African Americans living below the poverty level as compared to those over twice the poverty level are 3 times more likely to report psychological distress. And in one of the largest community mental health studies ever conducted, it was reported that there's an inverse relationship between socioeconomic position and prevalence of psychiatric disorders. So the higher your socioeconomic position, the lower prevalence of psychiatric disorders. And all of these facts are referenced, and we're going to be giving you all this in case you find anything particularly interesting. You can find the article where it was taken from. So we're going back to our case of Mr. John W. I'll reread it just so we all refresh what's going on with him. A 55-year-old African-American man with past diagnoses of bipolar disorder type 2 and multiple substance use disorders, cocaine, cannabis, alcohol, in remission. He reports years of anxiety, depression, low mood, guilt, and intermittent hopelessness with suicidal thoughts. He also experiences auditory hallucinations that tell him you're worthless and you're nothing but a crackhead. So given the time, we're not going to break up into groups or anything to discuss, but I want to pose this question to you all. Is individual treatment the right cure for John W.'s problem? So just think about it. If you want, you can share some of your thoughts in the chat, but we're going to go on to the pyramid. So this is the CDC's health impact pyramid that Bruni discussed in detail earlier. But I just want to reemphasize how at the top we have the smallest impact items such as counseling and education. So this includes things like, oh, you should eat healthy and you should be physically active. But at the bottom, you have socioeconomic factors, which really include poverty, education, housing, inequality, all these things that we've been talking about throughout this whole presentation. And that really has the largest impact on taking care of someone. But again, it sounds like, oh yeah, that's easy, right? But it's still a problem, and it's definitely not easy to fix these issues. So just really keep this in mind, how the reason we focused on all of these factors is because it really has the largest impact on health. So next slide, please.
I feel that I think before we go into the last take-home points, is it okay to just ask people, how they feel about John W. now after they know all these things that have happened in their lives? We could take like a couple minutes, just talk about that.
Yeah.
Is there anyone that would like to just speak about? Let's just bring up his case. I know one thing that I would like to point out is, his auditory hallucinations that tell him you're worthless and you're nothing but a crackhead. Again, like that's reiterating some of the internalized racism that, could have gotten into his brain throughout the years he's been alive. Yeah.
I also believe that John W., one of the reasons he resorted to crack, cocaine, whatever it was, to get some kind of solace, some kind of comfort to ease his mental state that was going on, and then that carried on to other things, but which he was not treating bipolar. Some say when they have those issues, they want marijuana or something to give them some kind of peace and some kind of comfort for their brain and mind. And so that leads to those kind of drug abuse without having any kind of medication.